Dermatology from the platform of Clinicopathological Medical College. We'll start the session with the name of Almighty Allah. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد صدق الله العظيم. Before moving on to the session, I would like to welcome our Principal Clinicopathological Medical College, Professor Masood Ahmed Sheikh, for the opening address. Professor Masood Ahmed Sheikh.
Thank you very much, Maida, for inviting in this CPC of the dermatology, the first ever CPC by collaboration of the Fazaya Rutfa Medical College and Brooks Pharma and the Department of Dermatology. I congratulate Dr. Humaira, who is our head of department, and Mr. Yasir of the Brooks Pharma for extending their help, and the Pakistan Association of Dermatologists for organizing this event, or I should say for letting the Fazaya Rutfa Medical College to hold this event at Fazaya Rutfa Medical College and contribute in the progression and in the propagation of the knowledge and information and update regarding the field of the dermatology. I hope the viewers who have joined on online through Zoom, they will get benefit through this arrangement. The speakers who will be talking today, they will be able to, update information regarding the dermatology, and this update will definitely bring some improvement in the patient care, and the update the participants, especially the professionals, the young professionals who have joined this Association of Dermatology in their knowledge and help in filling the gaps in their knowledge. So once again, I congratulate the Brooks Pharma. Brooks Pharma has done excellent job recently, especially Mr. Yasir has, just changed the pace of, the contribution of the pharmaceuticals industry in the organizing the events of like conferences and seminars, which gives a chance to the professionals to sit together and to work together. So I congratulate Brooks Pharma, I congratulate Pakistan Association of the Dermatology, who are continuously working towards, the betterment and towards the upgrading the information and contributing in organizing such events for the propagation of the knowledge and for the updating the young physicians, especially who are working in the field. So thank you, Dr. Madiha Farhan, for inviting me for this, opening remarks. And I would request you to please continue with your program. Thank you very much.
Thank you, sir. Thank you so much. Now we'll proceed with our session. And I'm going to present my first case. Questions will be taken after every case. You can jot down your questions in the chat box and your queries will be answered, inshallah. So our first case is an 11-year-old schoolgirl who is a resident of Mali, and she presented to our clinics with a slowly growing, non-healing painless plaque on the right side of the neck for the last 8 months. And she presented to us with her mother, who explained that this actually started with a small raised bump on the right side of the neck around 8 months back. And eventually it ruptured to form a large crusted lesion, which was oozing and very spreading from all sides of all aspects. And then it was treated. They took her to several doctors, and many treatments were given. And the treatments, when we asked them, it totally comprised of topical and systemic antibiotics. She had multiple courses of topical and systemic antibiotics, which resulted in only partial clearance of the lesion. She failed to reproduce most of the prescriptions, but she said that most of them comprised of the antibiotics. So suddenly what happened that after around 8 months, the lesion suddenly started spreading circumferentially, and then it urged them to bring the patient to us. Now, the systemic review did not reveal anything remarkable. Her past history, besides the 8-month history, it was not significant. Family history was also not significant. Drug history, as I've already mentioned, only comprised of antibiotics, antiseptics, and antihistamines on some instances. Then there was a history of travel to Multan 1 year back. When we did a cutaneous examination, there was a large plaque of around 12 by 12 centimeter, which is pretty large, and it was covered with thick plaque crusts with oozing and impetiginization. And the borders were raised, small red papules and pustules. And there was a curatorily formed ulcer in the center of the lesion. So this was when she was brought to us. This was the initial picture. You can well appreciate that there are the raised borders, and in the center, the whole lesion is oozing with purulent discharge and impetiginization. So we based our differential diagnosis on its first appearance, because when it presented to us, it was all impetiginized and covered with pus. Our first differential had to be impetigo, and then lupus vulgaris, which seemed to be superinfected, cutaneous leishmaniasis, and squamous cell carcinoma. Now, impetigo was already kind of ruled out because she had already taken several different kinds of antibiotics of different groups. So when it failed to respond to any of them, the first differential was already ruled out. Then we also, squamous cell carcinoma was also unlikely, but on the basis of appearance, we put it in. So the main differentials were either lupus vulgaris or cutaneous leishmaniasis. So without wasting any further time, we planned a skin biopsy for her. On examination, systemic examination only revealed cervical lymphadenopathy, and the routine investigations, the baseline investigations, all were normal. Now, when we did her skin biopsy, dermatology revealed dense chronic inflammation with few epithelioid cells and numerous LT bodies or amastigoles, which is seen engulfed by histiocytes. So it was pretty obvious by the biopsy report that the diagnosis was cutaneous leishmaniasis. So one of our differentials was finally confirmed. So we began our treatment with injection glucantime, meglumine antiminate, 20 milligram per kg per day, intramuscular for 4 weeks. This seems to be a very simple case. As you can see, a clear-cut case of cutaneous leishmaniasis. When it was biopsy proven, we started with meglumine antiminate, and the story seemed to be end here, but it had not. It didn't end here, and there is another angle to the story. The patient, she left for Multan. Apparently she couldn't get the injections over here. So she said that she would go to Multan to get the injections. And then we didn't see her for the next 6 months. Now, when she presented again after 6 months, she presented in a state like this. The plaque had grown even larger in size. It was totally crusted. The impetiginization, the oozing or the wet part had somewhat resolved, but the plaque was still there, the ulcer was still there, the borders were still active and raised, and they were circumferentially spreading. She was immediately placed on glucantime, that is meglumine antiminate. So you can see that these are the serial photographs we took while the glucantime course was going on, and you can see that the lesion started resolving, the crater started healing, the ulcer The borders, somewhat, they became depressed, and overall, the lesion improved. But after 3 months of commencement of the treatment, some active borders, they still persisted. You can see, you can appreciate that after 3 months, there are certain active borders, and they were still there. So we did cryotherapy. Cryotherapy is, as you know, done by liquid nitrogen. And we did cryotherapy along the edges to stop the activity, and which was successful. So the borders also, after some time, they showed improvement. Now, as I mentioned earlier, it was not a very difficult case. It was not something to discuss actually with the senior dermatologists, but there were certain points that I would like to discuss on this platform, which urged me to present this case in front of such senior faculty members. My first point is, why wasn't the patient advised skin biopsy during the first 8 months of her illness? Because during the course of her illness of the past 8 months, when she first presented to me, she had visited numerous dermatologists, and she was only prescribed with topical and systemic antibiotics. Now, if one antibiotic didn't work, and second didn't work, and third didn't work, why did anyone think of any other differential? And why wasn't skin biopsy planned? So this is my first point. Second point is, why didn't she get the injections after biopsy, which we had already prescribed the whole course, and she got lost to follow-up. And when she presented after 6 months, even then, not even a single injection had been given to her. So when we dug the history from her and we persuaded her to give us the whole history, there was a form. She told us something very strange, which answers my third point. That is, was there any violation of code of medical ethics during the course of her disease? When she went to Multan, she was enrolled into a research study, according to the mother, without her consent. And we are not known about the study. We don't know what medicines were given, what trials were done. But for the 6 months, she was enrolled into that study with some new drug, which was given to her without any resolution of her symptoms or her disease. And she was continued with that treatment. And in the end, she was told that in the end, she got to know that she was a part of that study. So that is a very alarming point, or a very alarming situation, which is something that should be addressed over such platforms when we discuss simple or complex cases. So the purpose of this CPC dermatology is not only to present cases and to create awareness, but it is also to address such unethical practices going on in our country and worldwide. And they have to be, their measures should be taken in order to, so we should discuss these things and we should take some action against it. So the discussion is, you all know, cutaneous leishmaniasis. It is a protozoan-borne disease, and it is the second largest parasitic killer in the world after malaria. And it is transmitted by bite of sandfly species phlebotomys. It is classified into cutaneous, mucocutaneous, visceral, and post-Kala-azar dermal leishmaniasis. And these are the major species which are involved here. In Pakistan, it is endemic almost all over. Now, in Balochistan and Sindh, the anthroponotic and zoonotic variants both persist, whereas in Punjab and KPK, anthroponotic venous leishmaniasis, that is the human vector human variant, that is prevalent. So now leishmaniasis all over Pakistan, almost. These are the wet types, and this is the dry type. Now, diagnostic criteria is history of exposure to an endemic area, which in her case was Multan, history of sandfly, which she did not give, history of high-risk activities such as sleeping outdoors, and a non-healing chronic nodular ulcer, which in her case was present there for the last 8 months. demonstration of amastigotes in the dust stain smear, demonstrations of amastigotes in the biopsy, which was in her case, presence of leishmanial granules or PCR of leishmanial DNA. The investigations we perform are skin smear, skin biopsy, culture, leishmania skin test, and PCR, which is the gold standard. Treatment is sodium stevogluconate and meglumine antimonate, which is the treatment of choice, which we still follow once daily, IV or IM injection antimony, 20 milligram per kg per day for up to 2 weeks, depending on the severity of lesion. And other drugs are fluconazole, 200 mg per day orally for 6 weeks, miltefosine, which is a comparatively newer drug, 50 milligram twice day orally for 3 weeks. Colchicine and itraconazole can also be given. We can also inject this antimony, meglumine antimonate, intralesionally into the lesion. Cryotherapy, as we did in our case, it is also useful in small lesions, but in this case, we did it on the borders, which was quite successful. And it can also be treated by local excision, curettage, or electrodesiccation, but it is associated with relapse. Surgical excision is not recommended as there is high risk of relapse and the cosmetic disfigurement. So, if there are any questions, you can put them down in the chat box. And I would like to welcome my professor, Professor Humaira Mariam, to give the closing statement of the case or the conclusion of the case.
Assalamu alaikum. Thank you very much, Dr. Madiha. The point of presenting this case on this platform is actually it was a simple case and everyone can go for the treatment. But the point is whenever we find any case of non-healing ulcer, nodule, or even a plaque, just like this one, for more than 6 weeks, why we don't go for a biopsy? We should make it a habit, not in all cases, but this is the most important tool of diagnosis in the field of dermatology. और लोगों के पास और बहुत सारे tools होते हैं जिससे वो diagnosis या clues निकाल लेते हैं, मगर हमारे यहाँ अभी तक ये trend नहीं है. Are actually lacking in this in the investigators, especially as far as the biopsy. Immunofluorescence तो बहुत आगे है. वो हमारे यहाँ बहुत ज़्यादा होती भी नहीं है, लेकिन it's quite expensive. But biopsy in certain centers, biopsy is done with a reasonable price. So why don't we go for biopsy in such cases? Because this is not the only case. I have went through many cases. They were treated as psoriasis, but later on they turned out to be They turned out to be the cases of fungal infections. Initially, they were treated for psoriasis or eczema, but later on, they were actually the fungal infection. So we should go for biopsy if our patient is not giving any response for the conventional therapy. Number two, this patient didn't know what she was given in the Multan. And but she was for sure that there was no injections intramuscular or intralesional over there. She went there because she heard that this type of disease is prevalent in Multan. So she went there because glucantime injection was not available in Karachi at that time. They didn't tell her what they are going to give her, but they started her on any therapy. After 6 months, when she came back to us, she had very worse condition. We don't have a right to give such ugly disfiguring scars to our patient. So we have to be very ethical regarding that thing. And number three is to treat this patient with other modalities also. at the end of treatment, when I found that the borders were not convincing with the clear of disease, I would like to say thank to Dr. Shamuna Tirmizi, because I sent her for cryotherapy to her. She did her cryotherapy with borders of the lesion to treat the borders. And beside that, one more thing I would like to thank to her. She started her on miltefosine, but the patient developed some side effects of that, so we had to stop it over there. So thank you so much, Dr. Shamuna. We have to discuss things with each other in the field of dermatology, and also we can take help from each other for the betterment of our patients. So thank you very much from my side. If you have any questions, we can answer it right now. Dr. Madiha is going to answer the questions. Thank you very much.
Thank you so much. So we'll begin with the next case. So our second case is of a 35-year-old married male who was a security guard by profession, and he was a resident of Hawke's Bay, and he presented to our clinic with multiple painful and itchy blisters and erosions on the groin area for the last 1 month. Now, his history of presenting complaint was that he did not have any previously known comorbids, and the painful blisters, which we saw, just appeared around 1 month back. They ruptured to form erosions and within 24 hours, and then new blisters developed. He had been using topical antibiotics. Again, in this case, only antibiotics were given to this, and only topical antibiotics, no systemic therapy, and there was no response. His past history and the drug history was not significant. Systemic review did not reveal anything significant at that time when he first presented. Cutaneous examination revealed multiple flaccid blisters and hemorrhagic erosions present on bilateral inguinal regions, and Mikulski sign was positive. Mucosal surfaces at that time were normal. So these were the initial lesions, actual lesions of the patient when he first presented to our clinic. And you can appreciate there are multiple small erosions on the groin area and in the surrounding area as well. Initially, they were small flaccid blisters, but they ruptured within 24 hours to develop into these erosions. The systemic examination was unremarkable, and the patient was vitally stable. His baseline investigations were done, and blood CP, UC, LFTs, all hepatitis profile, the X-rays, they were all normal. Skin biopsy was sent for histopathology and direct immunofluorescence, which confirmed our clinical diagnosis of pemphigus vulgaris. Histopathology showed classical intraepidermal blister with acantholytic cells, whereas direct immunofluorescence showed supravasal deposition of IgG and autoantibodies. Now, unfortunately, we were unable to get the hold of those slides, but I will be sharing the biopsy report. It was done from SIUT, both the histopath and the direct immunofluorescence. So after thorough examination and detailed preliminary investigations, we placed him on oral prednisolone, which is the first line of treatment for pemphigus vulgaris, and then azathioprine. After we prescribed these medications to the patient left and he got lost to follow. He did not show up for more than 3 to 4 months. Now, more than 3 months later, when he returned with severe generalized cutaneous disease, severe oral mucosal involvement, difficulty in chewing and swallowing resulting in weight loss, and swelling on right lower face. So we had to admit the patient to our dermatology ward immediately. On examination, the patient looked irritable with sunken eyes, looking much thinner, emaciated than before. Generalized erosions with few flaccid blisters, they were present all over the trunk and limb. There were erosions and whitish crusts on the lips. The whole lips, they were involved. And he had difficulty in opening the mouth. Both of the lips and the angles were full of erosions. And there was a tender submandibular swelling on the right side. Oral cavity, Examination revealed a large 5 by 3 centimeter erosion on right buccal mucosa and diffuse white curly membranes with multiple small erosions all over. So you can see, this is the cutaneous examination picture. You can see his body is full of flaccid blisters, full of hemorrhagic erosions, and the whole disease has now become generalized, which was initially only confined to the groin. There were two types of lesions, as I earlier mentioned. One was a large, non-healing, ulcerating type lesion, ulcerative type lesion on the right buccal mucosa, which you can appreciate near the molars, upper molar, right upper molar, and rest of the whole oral cavity was filled with this curdy white membranes. Now, patient, according to him, he had been taking this prednisolone and azathioprine unmonitored and unsupervised by himself when he was presented again this second time to us. So all the baseline labs, they were done again. Now the blood CP, UC, LFT, urinary, X-rays, hepatitis profile, all was again normal. Treatment continued, so we had to continue the treatment again with tablet delta cortical 80 milligram per day and tablet Imuron, which is azathioprine, 15 milligram twice daily. Meanwhile, we saw that his thrush, the candidiasis, the whitish curdy membranes involving his whole mouth, oral cavity, and the lips, it was progressively worsening. And it was not responding to local antifungals because initially we only gave him local antifungals. So we decided to start high-dose oral antifungals because we couldn't stop, we could not hold this tablet, delta cortical and Imuron at that time. So we planned that we should go with high-dose oral antifungals. So again, his liver profile was sent and liver enzymes, they came out to be really deranged. ALT was 117. And so we sent his hepatitis profile again, and hepatitis B surface antigen at that time, it was reactive. And then we went for the hepatitis B virus PCR, and which came out to be positive. So at that time, there were two challenges which we had to face. We had to treat his severe mucocutaneous disease because now his pemphigus not only involved the skin, it also involved the mucosa. So we had to treat the severe mucocutaneous disease in the presence of active hepatitis B virus infection. And then the second challenge was treatment of oral disease in the presence of severe mucosal candidiasis, because now his oral cavity had two types of lesions, pemphigus and candidiasis. So we had to adopt a multidisciplinary approach in order to proceed further, and we had to involve the following specialities: ENT for the submandibular swelling, maxillofacial surgeon, gastroenterologist, and medical specialist. Oral mucosal biopsy was done by maxillofacial surgeon because we were of the opinion, that it might be the swelling on the right buccal mucosa, the ulcer on the right buccal mucosa. It can be a part of the candidiasis as well. But it turned out that it was an erosion of pemphigus vulgaris. Ultrasound abdomen done by gastroenterologist showed unremarkable study. So he went for fibroscan of the liver to see the status of the liver, which showed grade F0 to F1 fibrosis. So the liver was pretty healthy at that time. Fiber optic direct laryngoscopy done by ENT showed no other findings except extension of that thrush down to the pharynx. So now the treatment was oral tenofovir, which was started by our head of the department of gastroenterology department, Dr. Kamran, and along with Dr. Basit of FRPMC. And they began this treatment because they were totally involved with us during the course of his illness. Delta cortical and Imuron, they continued because the gastroenterologists were of the opinion that because they went for the delta antigen, and the delta antigen of hepatitis B came out to be negative, so they said that this should not be stopped. It can go on along with the oral tenofovir. Capsule fluconazole, 150 milligram once weekly, and fluconazole 50 milligram once daily was started for the fungal infection. Topical steroids were given for the pemphigus lesions, and oral metronidazole gel and a statin drops were given for the oral candidiasis. Slowly and gradually, his condition improved. Patient remained admitted for around 4 months in our ward. Pemphigus lesions, they responded well to the therapy except the oral ulcer, which healed just before discharge. And oral candidiasis also took 3 months to resolve, with resultant improvement in oral intake and his overall improvement in his health and well-being and his weight. Now, when he was discharged, there was complete remission of mucocutaneous disease. The steroids were being tapered at that time. He was not on steroids, but they were being tapered. Complete resolution of candidiasis. Liver status was same as initially, that is, the liver was still healthy. And now he was advised regular gastroenterology follow-ups along with regular dermatology follow-ups. Now he is on regular monthly follow-up. Alhamdulillah, he's off steroids and he's still in remission. And it has been more than a year now. So in the end, I will conclude this case. Again, it is a very simple case according to the, keeping in mind the dermatology, because pemphigus vulgaris is a disease frequently seen by us. It's a very common autoimmune blistering disorder. It presents to us, and he presented with a very classical presentation of pemphigus. Even before doing the biopsy, we knew the diagnosis. And but my point of presenting it here was that multidisciplinary approach should be adopted, because in this case, the patient suddenly developed hepatitis B, and had we not been monitoring him and had we not involved the gastroenterologist and the maxillofacial and the ENT specialist and the medical specialist on board with us, he could have gone into liver failure. And next point is, the other point is that we should not hesitate to give immunosuppressants, because even when we discussed it with the gastroenterologist and medical specialist, they were of the opinion and they were on board with us on this matter, on this point, that while we are treating a patient in a tertiary care hospital, we have all the facilities over there, we have all kinds of investigations there, we have all kinds of specialists present over there. So we should not hesitate to give the patient the maximum treatment, the aggressive treatment, in order to induce remission in that flare of that disease, because he presented to us with a flare of pemphigus. So these were the 2 points which were in my mind while presenting this case. And I would like to, because research has been going on and there are many articles worldwide which have shown that while the patient is on immunosuppressants, especially injection rituximab, which is very popular nowadays in pemphigus vulgaris treatment, which is a biologic. So during that immunosuppressant and biologic therapy, there are many patients who go into reactivation of hepatitis B virus and even reactivation of many other diseases. So there's an article I'm going to mention here, in which they did a study, and they concluded it. The concluding point of this article was that hepatitis B antigen positive patients, if we are treating a patient of pemphigus with immunosuppressants or biologics, or even if not biologics, simple immunosuppressants like azathioprine or methotrexate, we should always go for serial liver profile and hepatitis profile, because there have been cases reported of activation of hepatitis B in patients on immunosuppressants in pemphigus. So again, I would like to call Professor Mara Miriam to give a concluding discussion.
Thank you very much, Madhya. Thank you very much, Madhya. I would like to read this part of the article. Basically, it was the article regarding hepatitis B positive patient on immunosuppressive therapy due to any reason. This is actually the study of hematological malignancies. So they say that hepatitis B surface antigen positive patient should be referred to a viral hepatitis specialist for assessment if the treating clinician is unsure of the appropriate management for the patient who is hepatitis positive. they should consult a viral hepatitis specialist. Guidelines. Positive hepatitis B surface antigen indicates a diagnosis of chronic hepatitis B infection. Due to the complex nature of chronic hepatitis B infection during immunosuppression, especially, we recommend that all hepatitis B surface antigen positive patients are referred to viral hepatitis specialist. Assessment follows existing guidelines for the assessment management of the patient with chronic hepatitis B, and a serial of the surface antigen repetation and anti-HBe antibody and its DNA, LFTs, blood-borne virus serology, like hepatitis A, C, D, and HIV also, and potential complications of chronic hepatitis B, such as liver cirrhosis and hepatocellular carcinomas. So they also say that a positive patient do not, generally the hepatitis B positive patient do not routinely need to be referred to viral hepatitis, but especially when they are put on immunosuppressive therapy, we should consult the concerned department. So it is very important for us, especially because the majority of our problems are immunologically mediated, especially in dermatology, like pemphigus, SLE, and all these. We have to discuss such things. If we find any infection, we have to discuss with the infectious disease specialist. And this is the competency of a consultant. Just like Dr. Kamran, I must thank to Dr. Kamran. They said, you go ahead with your treatment. We are here to deal with our part of the, and he started the patient on antiviral therapy. We started and continued our patient on immunosuppressive therapy. And Alhamdulillah, our patient is in remission for the last 1 year. 1 year, he is on in remission without corticosteroid because azathioprine. I saw a patient, he was taking steroid 5 milligrams once daily for last 2 years. And he was a patient of bullous pemphigoid. All dermatologists know that bullous pemphigoid is much easier to treat than pemphigus vulgaris. But he was taking this drug without any logical reason behind it. And some dermatologist or someone gave him on this. When he presented to me, he was tremoring. He had very fragile skin, multiple bruises, and he was 60 plus patient age. We tapered him his treatment. Now, Alhamdulillah, he is much better. His all the comorbidities that developed due to corticosteroids were all improved, and now he is off the treatment for immunosuppression. So we should take a multidisciplinary approach in every aspect of medicine and allied, especially in dermatology, because we deal with immunologically mediated diseases. We have to consult with our counterparts or consultants regarding any. So this was the take-home message, to consult other disciplinary fields to treat your patient, because the patient is the priority. Thank you very much. And now we will answer the questions. If any questions are there, Dr. Madhiya will respond to questions.
Dr. Sana, you asked for the slide, the treatment slides. I'll show you the treatment slide again. So you asked for the treatment slide in this patient. We were giving, as I said previously told, oral tenofovir. It's an antiviral given by gastroenterologist. Delta Cortal 80 milligram. We started from 80 milligram per day, and then Imuron 50 milligram twice daily. Then intralesional Kenacort triamcinolone was given into the buccal pemphigus ulceration, and it really helped a lot because we were not applying any topical steroid into the oral cavity due to the fact that he was on antifungals, and any topical other antifungal steroid would flare the oral thrush. So this is the treatment slide which you asked for. And I can, already asked for the pictures. I can show you the pictures again. I can show you because I think this was presented in a bit hurry. This is a serial photograph of the Leishmania case. Again, who joined late. I want to show the pictures of this case again. The initial presentation, then lost to follow-up, and again represented with these lesions, and then on glucan-time treatment. And then cryotherapy and after cryotherapy. So these are the serial photographs. The Imiron dose, Dr. Sana, Imiron dose is, I told you, 50 milligram twice daily. He was on azathioprine, 50 mg twice daily. So if there are no more questions, yes, ma'am.
This is an autoimmune disease.
No.
So fungal infection is superimposed on that, or that was a separate entity?
Fungal infection is a common presentation of patients who are on immunosuppressive therapy. So we have to go together with the antifungal therapy. Mostly it happened that in long-term therapy of these type of diseases, we do have encounter with the fungal infection, especially oral, as well as in case of females, genital fungal infection can occur in such patients. So this is the thing that we always keep ourselves ready for the treatment of these diseases. And the second thing was there are two things. One thing is that hepatitis B has two type of presentations. One is acute and the other one is chronic. Sometimes acute can disappear after some time, some weeks. And then due to this condition, maybe they reappear. But this patient had no any region, so he may have developed during the course of loss to follow-up this condition. So we have to go for the concomitant therapy of antivirals like this. No. Actually, the lesions, skin lesions are the pure lesions of skin disease, the pemphigus vulgaris. Blisters, oral lesions were no. Initially, the oral lesions were the lesions of pemphigus vulgaris because the biopsy proved the non-healing ulcer that was present on the buccal mucosa was the lesion of pemphigus vulgaris, and it improved with the intralesional triamcinolone. It was the actual disease. It was the actual disease, the pemphigus vulgaris. And actually, because we were not able to give him oral topical corticosteroids because of the candidiasis, so we put him on the intralesional triamcinolone.
And that was the reason that we involved the maxillofacial surgeon from CMH, Brigadier Saab, because that was the reason, because he is an expert of his, and he was the one who gave the intralesional triamcinolone to the patient. He was the one who went for biopsy. So he was also a part of our multidisciplinary team during this case. And I would also like to thank our assistant professor, Dr. Javed Wasim, because he was the one who initially diagnosed this patient of pemphigus, sir, and we proceeded with the case.
This is a case which is really interesting, appears interesting to me, because it is very difficult to treat patients with hepatitis B infection, along with PCR positive with viremia, and of course the fibroscan shows 0 to 1. So that's good point, but it's very difficult, and it's a double-edged sword which can do anything. So it was really very much challenging to treat this patient. With treatment with steroids, 80 milligram, with viremia, viral PCR positive. So you have to have a big hand for this treatment, challenging treatment for both departments, dermatology as well as gastroenterology, because it's not easy way to treat these patients.
Now, ma'am, now he's on regular. Now he's on regular dermatology as well as gastroenterology follow-ups. And Alhamdulillah, his liver status is still the same. And this, as ma'am earlier pointed out, Dr. Omera, that this was a really big challenge for us, but we did not hesitate due to this strategy of putting a multidisciplinary approach and involving everyone from our tertiary care hospital and addressing all the issues simultaneously. Yes.
Because you have to counsel him that this is the duration of your treatment and you have to take. Now, was he transferred to the
Ma'am, actually, he was, as I told you earlier, he is a security guard by profession. And he basically belongs to some area in Punjab. He's not a permanent resident over here. His job has, due to his job, he's residing here in Hawke's Bay. Even his family was not here. He is living as a single over here. So when we gave him the treatment, he was in a very bad shape. Earlier, his disease was not that. I told you earlier that his disease only involved the groin. So what he did, which he later told us, that he took the treatment and then it went to his village. Because most of the people who come from other areas, other cities, when they get sick and when they are not well, they prefer to leave their job and take some leave, and they prefer to go back to their hometowns or villages. So that's what he did. But what he did wrong was that he took a bulk of Delta Cortical and Imuron with him, and he just took them off and on. And due to that, his pemphigus also went into remission, and he developed all the superimposed infections, like the candidiasis and thrush, due to that unsupervised and unmonitored intake of prednisolone and the immunosuppressant. So that is the main reason. Thank you.
Is there any other question on the Zoom members? Or any comments from our...
Appreciating
Dr. Humaira. Dr. Sadia is, I think, not here for her commitments. I would like to thank Dr. Humaira, Dr. Sadia Tabassum from Aga Khan and Civil Hospital, and Pakistan Association of Dermatologists. Thank you very much, as well as the CPC Dermatology team for giving us this opportunity to present such challenging cases over here. And I would like to say thanks to Dr. Shamuna for her help and support. And I would like to thank Dr. Kamran, the gastroenterologist, who supported us in this challenging case for us. So always, I just want to say one thing, that all my juniors, please, whenever you see any patient who is not responding to conventional therapy, go for biopsy, because there are certain centers who do the biopsy at reasonable rates and prices. So always go for biopsy, because our patients are really suffering a lot. Thank you very much. At the end, I would like to thank Brooks Pharma, whose support, without whose support, we were not able to continue this thing. Although there were challenges for them to pass the gate, especially in our setup, but they anyhow they make it possible. Thank you very much, all who supported us, and the audience also who supported us and asked questions. Very, very reasonable. Thank you very much.
Thank you. Thank you, Dr. Humaira. Thank you, everyone, for the wonderful comments. Thank you. Thank you, Dr. Shamuna, Dr. Izwan, Dr. Mariam, everyone who has commented. Thank you so much for participating. Thank you so much for listening to us. And thank you, everyone, the audience present over here in the lecture hall. Thank you so much. And inshallah, we'll be doing more of these activities and sharing more of these wonderful cases with you. Thank you.